Our topic of discussion here is going to be bypass urinary incontinence. I'm just going to warn you in advance here, my phone's been blowing up all day, so hopefully my phone does not go off while I am recording this. Okay, a 46-year-old woman presents to the clinic complaining of persistent urinary leakage over the last week. She says that she is constantly changing pads because of wetness, and this occurs both during the day and at night while she's sleeping. She cannot think of anything that makes it worse, and that the leakage is more or less the same no matter what. However, it does get worse if she drinks more fluids. She is able to urinate without difficulty when necessary. 2 weeks ago, she underwent an elective abdominal hysterectomy. The surgery was uncomplicated. She's otherwise very healthy. On physical exam, you note a properly healing surgical wound over the lower abdomen. Vaginal exam is generally unremarkable, though there appears to be urine within the vaginal vault. Urinalysis is within normal limits, and the cultures are pending. All right, so I'll let you pause it here if you want to sort of chew on this a little bit more. So the chief complaint here is urinary incontinence or involuntary urinary loss. And what this means is that we need to know the nature of the loss of urine. When is it happening? Is there anything that makes it worse? How much is it? Is it a large amount all at once, or is it sort of a constant amount throughout the day, or is it intermittent? Is it we get this here out of our history. We know that it's constant. She's constantly changing pads. It happens both during the day and at night, and there's really nothing that makes it worse or better other than that if she drinks more fluids, it's going to be worse, and that generally holds for any kind of urinary incontinence. The more urine you have, the worse it's going to be. So what can we rule out right away? We can rule out stress urinary incontinence. Remember, stress urinary incontinence is the only one that occurs only during the day. It doesn't occur at night. Now we can probably also rule out urge urinary incontinence, because with urge urinary incontinence, the most prominent feature is going to be this persistent need to go to the bathroom frequently throughout the day, 9, 10, 12, 15 times per day. And also waking up to go at night. Now, she's losing urine at night, but she's not waking up to go to the bathroom. So really that narrows it down to bypass urinary incontinence or overflow urinary incontinence. Now, how do we know it's not overflow? Well, the fact is that she's able to pee when she wants, and she's able to empty her bladder if it's necessary, but she's still losing urine. Now, with overflow urinary incontinence, what the problem there is that they're not able to empty their bladder. Their bladder just fills up, and then eventually the pressure in the bladder exceeds the pressure in the urethra, and the bladder just begins to dribble out. That's not happening here. So we can pretty much identify this just based on that as bypass urinary incontinence. Now, there's something in her history that also suggests bypass, and that is the fact that she's had pelvic surgery. She had an elective abdominal hysterectomy, as we're going to see. Hysterectomies make up 50%, more than 50% of cases of fistulas causing bypass urinary incontinence in the U.S. It's the most common cause. Otherwise, there's really nothing else really significant here. Now, sometimes if you do a vaginal exam and there is a fistula, you may be able to identify it, but not all the time. Okay, and it doesn't really help us for our purposes, because if you don't have if you just simply see the fistula in the vagina, it doesn't really tell us where it's coming from, and that's going to be really important when we diagnose the patient and send them off to the urologist to have corrective surgery. All right, so these are the important factors here. All right, so overflow urinary incontinence and bypass urinary incontinence look a lot alike when it comes to the symptoms, but the major thing that's going to differentiate it, and it's going to be very obvious when you talk to the patient, is the fact that bypass urinary incontinence patients can empty their bladder if they need to. Overflow can't. And typically with overflow urinary incontinence, there's going to be some kind of neurologic problem. So they're paralyzed, multiple sclerosis, Maybe they got an epidural a few days ago. And so there's generally some kind of neurologic issue going on there. Not the case with bypass urinary incontinence. There's no problem here with the bladder working. There's no problem urodynamically. It's just there is a fistula, and that fistula, there's no control over it. The urine goes through the bladder or through the ureter and directly to the vagina, and so there's loss that way. So pretty simple as far as pathophysiology is concerned. So it's caused by fistulas. As far as the history, then we're going to see incontinence pretty similar to overflow incontinence, but really the history and if you just know some of the basics here, the patient is able to void when desired, and so that really differentiates it out. Even though they look a lot alike as far as the history goes, there's some major things that's going to help you differentiate the two. So the patient's able to void when they want to, and there's not going to be any kind of elevated post-void residual because they can empty their bladder. Fistulas often become clinically apparent between 1 or 2 weeks post-operative, so it takes a little while for them to develop. They're not going to just come out of the OR and have fistula. It takes some time for it to develop. So here are three of the fistulas that are going to be important for our purposes as far as urinary incontinence. There's one more that's not shown here. So the rectovaginal fistula obviously is not going to cause urinary incontinence, but it is important because this can happen in things like Crohn's disease, where you get fistulization from the GI tract, and that can go into the vagina. You can get obviously. Imagine why this would be an issue, and you can get passage of feces into the vagina. Okay, so the vesicouterine fistula is a fistulization between the bladder and the uterus. Now, we don't see this as much because what's the most common cause? Hysterectomy, and if you have a hysterectomy, you no longer have a uterus, so that doesn't happen so much, but we will see a picture of that in a little bit. Vesicovaginal fistula is between the bladder and the vagina. Ureterovaginal fistula is going to be between the urethra and the vagina. And then there's one that's not shown here, and that is the ureterovaginal fistula. That would be between the ureter and the vagina. Now, in the developing world, not in the US, in the developing world, the most common cause is obstetric trauma, usually due to complicated labor and delivery that necessitates an operative delivery. In the US, on the other hand, the most common cause is pelvic surgery, particularly hysterectomy because it's so commonly performed, and pelvic radiation. The risk of developing fistula secondary to surgery is going to be higher for those who already have some kind of pre-existing pelvic pathology, so endometriosis, pelvic inflammatory disease, or who have received radiation beforehand. So pelvic radiation and pelvic surgery are together responsible for 90% of cases in the US, but just hysterectomies alone, because like I said, they are such common procedures, they account for the majority of cases in the US. And hysterectomies are done for all sorts of reasons, usually for benign reasons like fibroids, menstrual dysfunction, uterine prolapse, etc. How do we work this up? Any patient that has urinary incontinence, no matter what, we get a urinalysis and culture. So you do that, rule out concurrent UTI. You'll also want to get some basic blood work here. There can be renal problems associated with bypass urinary incontinence, so we just want to make sure that there's nothing going on here. So we'll get basic blood work, which is going to be a metabolic profile and CBC. So that's easy to do. Then we do this double dye test, and the USMLE loves to throw this at you because it's rudimentary and it tests your knowledge of the anatomy and everything. So what you do here is you give the patient two different kinds of dyes. One is going to be to inject methylene blue into the bladder, and that's pretty obvious how that works. So you put this dye into the bladder. If there's any kind of fistula between the bladder or between the urethra and the vagina, then you're going to have blue dye spilling out onto your pad or tampon or whatever's there. So hopefully that makes sense. So this is going to be involuntary. So if the patient urinates, she's going to have blue urine. But if there's involuntary loss and it's blue urine, then that indicates there's some kind of fistula between the bladder or the urethra and the vagina. Okay, so blue for bladder. The other dye is phenazopyridine or pyridium, and that identifies a ureterovaginal fistula. So a fistula between the ureter and the vagina. Remember, the ureter is not the urethra. The ureter is between the kidney and the bladder. So this is a dye that you take orally, and it gets filtered through the kidneys, and as it goes between the kidney and to the bladder through the ureter, if there's a fistula, it'll go directly to the vagina, and you'll have this orange dye that will stain the pad. So if you have orange dye, it is a ureterovaginal fistula. If you have blue dye, it's either a vesicovaginal fistula or a ureterovaginal fistula. Now, once you identify, get an idea of where the fistula is, you can do imaging. Typically, we go for CT uroscopy. However, the most definitive test is a retrograde pyelography. That is your best test to diagnose a ureterovaginal fistula. But really, if you get imaging, you're good to go. I don't expect the USMLE to go in too great of detail as far as what kind of visualization or radiographic imaging you're going to get. Typically, CT uroscopy will be your first step, but urologists might disagree with that. But what you will get, no matter what, on the USMLE, and I've seen a few questions that have talked about the double dye test, got to get this double dye test. And you want to know how it works, because I have seen questions that say, there's blue dye on the pad, where is the fistula? And you can deduce from that it's going to be either between the bladder and the vagina or between the urethra and the vagina, not between the ureter and the vagina. In that case, it would be orange. So just remember, blue for bladder or urethra. This is a vesicovaginal fistula, so we see the bladder here. Now this is not the double dye test. Here we have a radiographic dye that's injected into the bladder. And so we see that the dye is going from the bladder to the vagina. And so the fistula is right here. It's pretty faint, but you can kind of see it here. The arrows help you out too. This is another vesicovaginal fistula. You have the bladder here, and it is going into the vagina. So here is your fistula. And then this is a vesico-ileal fistula. This won't cause urinary incontinence, but it just happened to be on the picture. So I thought I'd point it out. Okay, so here we have a fistula between the bladder and the uterus. Now this would come out the same way. This would be a positive blue on the pad, and that's because it's just going into the uterus, and then from the uterus it'll come down through the cervix and then into the vagina. So here you see on imaging that there is a fistula between the bladder and the uterus. This is a ureterovaginal fistula, and you can see here. And another ureterovaginal fistula coming between the ureter and the vagina, filling it up here. And here's another one. Okay, so hopefully you got the idea. Management, surgical correction. That's all you need to know. You don't need to know how to do the surgery as usual for the USMLE. You don't need to know how to do it. Just know that you're going to be sending these patients off to a urologist. Okay, so pretty easy. Bypass urinary incontinence. It's going to be persistent leakage. Happens at night. Typically a patient who's come out of surgery or has gotten radiation to the pelvis. They're not going to have any kind of increased frequency or urgency. It's just going to be a constant, persistent loss of urine dribbling out throughout the day and throughout the night. They're not going to have any abnormalities on urodynamics. Their physical exam will be normal, although sometimes you can see the fistula in the vagina. Management here is just surgery. All right, so hopefully you got the idea here. This isn't a very common one to come up on the test, but it is not terribly uncommon in practice just because so many more women today are getting hysterectomies. So you may see this. I'll see you next time.